So for those who don't know me, I'm Dr. Rothman. I'm the Associate Program Director for POCUS. I think this talk is mainly meant to be, should be largely a review for all the interns who were able to go through the simulation lab, maybe a few months ago, I think during cycle 2. And then for, the other interns who didn't get a chance to hear the talk or learn about lung ultrasound then, this will be a great opportunity for you to get exposure to it. So what we're basically going to do is we're going to go through a quick rundown of lung ultrasound in totality, discuss the basics, maybe some pathologies, and then depending on the time, go through a series of sample cases where you guys have to sort of work through the diagnosis based on the images that you're seeing. And so obviously, I know it's just through Zoom, but if you guys can just be as interactive as possible, that would be great. So if something doesn't make sense, please feel free to speak up or mention it in the chat. I'm happy to answer any questions as they come up, okay? All right, so with that, we'll get started. Hopefully, all right, there we go. So yeah, so first things first, we just wanna know the basics of what it means to do appropriate lung ultrasound, and that starts with good technique, right? So for the purposes of this talk, we're going to be mainly utilizing the body probe, which is the smaller etched probe that looks almost like a square at the tip. But you can also do most of lung ultrasound with the vascular probe as well. And really, the only time you would want to mainly use the vascular probe is when you're looking at more superficial distances, so closer to the skin surface, looking at the pleura lining and other close findings that are subpleural. So with lung ultrasound, and it's going to be the same for abdominal ultrasound as well, the probe marker or the dot that's on the probe should always be pointing up. And so that under the normal circumstances, depending on your preset, should always correspond to the left of the ultrasound screen. So for the purposes of the talk, anytime you see the left of the screen, the dot is pointing up. And so the left of the screen equals cephalad, just to keep you guys oriented when looking at the images. And a complete lung ultrasound exam really should include 4 to 6 views per side. And that's going to be 2 anterior views. So you can see they've drawn like sort of an anterior zone. So you can do usually 1 or 2 rib spaces apart. So you want to have at least 2 anterior views, a mid-axillary view, which will just be along the mid-axillary line anywhere down above the diaphragm. And then you want to get another view either showing the diaphragm or even going posteriorly almost towards the mid-scapular region to look at the lower parts of the lung and the diaphragm. And then so this X-ray image sort of just delineates, the basic views. So these are your 2 anterior views. This is your mid-axillary view, and this is your posterior or further posterior lateral view or diaphragm view. And so each side should be at least 4 views. So just to review the normal lung anatomy, what it looks like on ultrasound, right? So if you look at just the schematic here, you have obviously your skin and soft tissue, which varies from person to person, but especially with the anterior lung views, there shouldn't be too significant in terms of depth. And then right below the skin and soft tissue, you have a layer of muscle, and then you have, you'll see sort of shadowing areas, and that's going to delineate sort of where the ribs are in the anterior structure. And then below, or in between and below the ribs, you're going to see elements of the lung. And this red line here is meant to delineate the pleura. And really, this is what it kind of looks like on ultrasound. They call it a bat wing appearance. I personally never really saw it as a bat wing. I don't know. I mean, I don't really look at bats in flight that much. But if you just want to try and appreciate that the ribs are sort of start out as bright white, and then below it is shadowing. And then you have in between the rib space, you can see this bright white hyperechoic line, and that's the pleural line. And then these are what we're going to talk about a little bit more. These are A lines. They're just parallel reflections of the pleura. And this is sort of what it looks like in using the standard body probe. And then this is what it may look like if you're using the vascular probe. You can see it's a more linear structure that you can appreciate the soft tissue a lot more clearly. And then the pleura is this, again, bright white line surrounded by ribs. So the basics of lung ultrasound consists of A lines and B lines. So what are A lines? So A lines are just hyperechoic horizontal lines that are equidistant repetitions of the pleural line. So this is the pleura right here. And then you have repetitions of that pleural line as you go deeper and deeper. And this just represents normal aerated lung. Normally, air is bad for ultrasound, right? So when you have normal aerated lung, once it sort of meets the pleura, the ultrasound can't really process and penetrate further. And so you just get these parallel reflections as sort of artifact. When there's something there besides air that shouldn't be there, then you get some other pathological findings. And so the most common one is B lines. And what B lines are these vertical, you can see hyperechoic lines. When they're usually singular or when you can count them, like when they're clearly delineated, it usually defines sort of thickened interstitium. And basically, the way that you can tell that these are B lines is that they're hyperechoic throughout the entirety of the depth of the screen. So whether your depth is 5 centimeters, 10 centimeters, 15 centimeters, the B lines should be going all the way down to the very edge of your screen, and it should be bright white throughout. And so for us to say, we usually like to classify the views as either A line pattern or B line pattern. So for us to say that this is a B line pattern, you want to see at least you want to see more than 2 B lines in a single lung field, and that would be considered abnormal. So that would suggest that there's something going on in that lung space that shouldn't be there, whether it's fluid, whether it's infection, whether it's inflammation, you can't really say for sure, but it's something that's not normal. And this is just showing the sort of the spectrum of B lines, right? Where you sort of start with one single one, then you have a couple of them. I think I count 5 here. And then this last one is sort of almost getting to the point where they're almost confluent. And when you see more confluent B lines, that's something that might correlate more with ground glass opacity seen on CT. So whether that's an infection or extensive pulmonary edema. So this is just showing lung ultrasound using a specific point called the PLAPS point, and that's really the posterolateral alveolar and pleural syndrome point. And so this is going to really be focused primarily on the lower lobe of the lung. And why do we care about this? Is because this is the most common area where you see pathology, whether that's atelectasis, fluid, pneumonia. And so you always want to look in this space when you're doing a full lung ultrasound. And this is, again, just showing the spectrum of things you might see. So you can find, this is what's called a curtain sign, where you have the liver here, you can see the diaphragm here, and then with a normal person taking a big deep breath, you have lung sliding interview, and that's sort of obscuring the abdominal findings. So this is a normal curtain sign pattern. Here, let's see, my video is not really cooperating. All right, there we go. So this is just showing, again, I think this is actually on the left side. So you have the spleen here. You have the diaphragm, which is the curvilinear bright white line. And then this black that you see, anechoic space, this is a very large pleural effusion. Can everyone appreciate that? You actually can't even see really lung floating into the picture. And then if you look, there's just another finding here. So again, you have your diaphragm is this curvilinear structure. You have actually a little bit of fluid here. And then you have, what looks almost like more liver, right? So essentially the same ecodensity as what you see the abdominal structures. This is essentially a hepatization of the lung. And so when you see something like that, that means the lung is consolidated. And we'll talk about ways that you can help differentiate whether this consolidation is an atelectasis or pneumonia. I would say in this case, you want to look at the bright white hyperdensities that you're seeing. And if there's movement with respiration, that means they're dynamic air bronchograms. And dynamic air bronchograms are more indicative of a pneumonia. If they're sort of still with respiration, meaning there's no air going in or out of that space with respiration, then that would be more indicative of an atelectasis. The other main thing we look for is lung sliding. And so really, what is lung sliding? So lung sliding is sort of when there's obviously 2 layers of the pleura, the visceral and parietal layers of the pleura, and under normal circumstances, those pleura are constantly sliding up against one another, and it's very pronounced with respirations. So when you don't see those 2 pleura sliding up against one another, you get what's called an absence of lung sliding. So this is just showing the difference. So this picture on the left, you can kind of appreciate there's some lung shimmering at the top. So this would be indicative of a normal lung sliding pattern where there's like almost shimmering at the pleural line. And this is in contrast to something here where you see absolutely no movement during respirations. There's maybe a little bit of like a heartbeat type movement, but there's really no movement. And so I guess this is like a quiz for you guys. So what might cause an absence of lung sliding?
Pneumothorax.
Right, excellent. Yeah, pneumothorax. Is anything else you guys can think of?
Lung consolidation.
Yeah, and more specifically, even like a atelectasis, right? So if that area of the lung is not getting aerated, right, the pleural lining is not going to be sliding up against one another. So fibrosis, it depends, I guess, on the severity. I think sometimes, you should still be able to see lung sliding with most cases of fibrosis. There's maybe like at least one other thing I can think of. Well, yeah, so pneumonectomy, and really what we're trying to get at is a patient who has a pleurodesis, right? So let's say for whatever reason they had a chronic effusion there, they had prior thoracic surgery where they ended up doing a pleurodesis. With pleurodesis, the whole idea is that you get the pleura to stick together. So post-pleurodesis, you won't see lung sliding. So this is, it depends on the clinical context. Obviously we're most concerned about a pneumothorax when we see an absence of lung sliding, but just keep in mind that there is a series of things that can cause the absence of it. So you don't necessarily want to go shove a chest tube in to the patient just because you see an absence of lung sliding. You need to do a little bit more digging. Then, so this, in contrast to just an absence of lung sliding, this is pathognomonic of a pneumothorax, because this is delineating the area where you have normal lung sliding. You can see on the left of the screen, or cephalad, right? In contrast to where you see a still pleura, right? So this is an absence of lung sliding. This is a presence of lung sliding. So when you see both of those in a single view, that's called lung point. And so this would, why is this important? This helps us delineate the extent of the pneumothorax, right? So a lot of times, do we have an apical pneumothorax? Do we have a lateral pneumothorax? Do we have a complete pneumothorax, tension pneumothorax? And it also makes us feel more confident in terms of where we're placing our chest tube. And then, what else could you maybe do if you're, not sure whether you see lung sliding? This would be more of like a review, like what other tools can we use with ultrasound to help delineate whether there's lung sliding present or absent? Okay, so Omar saying M mode. Okay, great. And do you guys remember the key signs or key names that there's two different signs on M mode? Okay, awesome. Archon barcode sign. What else? Seashore sign. Okay. Seashore. Excellent. All right. So of course I have examples for you guys just to jog your memory. So using the M mode to evaluate lung sliding, and again, M mode, M stands for motion. So it's, when you hit the M mode on ultrasound, you get this centrally located, maybe you can move the line depending on where you want your view, but this basically line will look at motion over this line for a period of time, right? And you can use it for a couple different things. Obviously it's well known in a lot of cardiac function, but definitely its main use in lung ultrasound is honing in on whether there's lung sliding in that specific area of the lung. So the A side of things, this is your normal pattern that you would see in a patient with lung sliding. And because basically once you hit the pleura and there's sliding, then you get sort of static below it. And so if you imagine, obviously everything, they try and come up with names for things. So if you imagine sort of the soft tissue area, that's sort of the wave-like pattern above the pleura. So those are sort of waves that are crashing in. And then the static below the pleura is your sand. So this is your classic seashore pattern, as opposed to a patient who does not have lung sliding. So there's no movement below the pleura. So instead of static below the pleura, you just get continued reflections of the subq and pleural space. And so you get these series of parallel lines. And so the most common name for it is barcode sign, but you may also see stratosphere sign in the literature. And so those two mean the same thing. So this will be another way of diagnosing the absence of lung sliding if you're not sure. Any questions on that? So another common finding with lung ultrasound is looking for pleural effusions, right? And so not all pleural effusions are created equal, right? So there's simple or there's complex. So the classic simple effusion is on the left of the screen, where you have basically primarily an anechoic fluid collection. This would be, again, a large pleural effusion. You'd have to, sort of dig in what potentially the cause of it might be, whether it's heart failure, if they're bilateral, if there's a paradomatic effusion. Sometimes fresh blood can look like this. And then this is in contrast to the image or the video clip on the right, where instead of a nice full anechoic fluid collection, you really see some pockets of anechoic swap, but there's really a lot of septation. Almost looks like a fishnet of loculations and septations. This would be a very indicative of a very complex effusion. I'd be, depending on the clinical context, I'd be very worried about an infected pleural space like an empyema. If I saw something like this, but other things can cause it. Certain malignant effusions can cause it. Certain chronic effusions can cause it. So you still want to use your clinical acumen to come up with a differential. And this is just sometimes we get asked like how much fluid we think there is within the pleural space based on what we're seeing on ultrasound. So there's been some studies. The most perhaps accurate way of estimating the pleural fluid is just taking the distance from the most cephalad part of the diaphragm, so like right here, and measuring, going in a straight line to the nearest tip of consolidated lung. And so that in millimeters times 20 estimates the pleural fluid volume. It's obviously not perfect, but it gives you an idea of, if you are planning on doing something like a thoracentesis, you can guess how much you may have to take out. All right, so this I kind of talked about a little earlier. But again, there's different types of air bronchograms. So we look at the term of air bronchograms comes handy when we're looking mainly at lung consolidation. And so really there's two main lung consolidations that we see in the clinical setting, and that's pneumonia and atelectasis. And so how do we delineate them? So one, obviously you can use your clinical context clues, right? The patient's febrile, they might have a white count, they're coughing up thick white sputum, or they're having they're a stroke patient who can't protect their airway, they're having recurrent mucus plugging events. So you can use your clinical judgment to sort of predict whether it's atelectasis or pneumonia. But another way to look at it is looking at these air bronchograms. And so basically, what we try and do is look for the hyperechoic bright white spots within the consolidation. Those represent the air bronchograms, and then you want to see if there's movement with respirations. So if there's no air moving in and out of that consolidation, if the air bronchograms are not moving, like we're seeing here, this is indicative of atelectasis. If in contrast, you can see like bright white aspects are changing as the patient's breathing in and out, that means there is some air movements within that lung, and that instead of like an airway being blocked, it might just be alveolar filling process like a pneumonia. So this on the right of the screen is dynamic air bronchogram. So this would be more indicative of a pneumonia. Some additional lung ultrasound findings. I did want to include something new that maybe you guys haven't heard of, even if you did the simulation session. So there's been a couple other signs that have been mentioned within the literature. So the first one is basically on the left of the screen. This is called a shred sign. And basically what this is referring to is the shredded appearance of the lung deep to an area of consolidation. And this results from ultrasound interactions with that interface. And so in this case, you may have a subpleural consolidation, which you can kind of make out up top. And this bright white line with some shadowing and B-lines below it represents sort of the boundary between that consolidation and normal aerated lung below it. So this would be another positive finding in a patient with a pneumonia. And then there's also something called a lumpy bumpy, very technical term, or fragmented pleura. And this helps us, let's say if we're seeing a patient with B-lines in a specific lung field, and we're not sure what those B-lines are coming from, we can pay special attention to the pleura and see, is the pleura nice, smooth, and even throughout, or is it fragmented or lumpy bumpy? And as you can see here, there's some fragmentation. There's like the pleura is down here, then it goes up here, then it goes down here, goes up here. So in this patient with B-lines and a fragmented pleura, this would be more indicative of an inflammatory or infectious process rather than something like a pulmonary edema type process. Any questions about these two extra lung findings? So with that, if there's no questions, we're sort of just going to go through a series of cases. And the idea is, obviously some of these are based on, real cases we've actually encountered on the ultrasound elective service. And then some I've sort of made up just to sort of get you guys extra practice. But So, we're just going to run through the cases, and then I'm going to ask you guys to just write in the chat or speak whatever you guys want, what you guys are seeing, and then we'll take it from there. So starting with case 1, so we have a 32-year-old man. He has history of end-stage renal disease, diabetes, hyperlipidemia. So he actually came in with an acute onset change in mental status. He was found to have an anoxic brain injury, which was theorized to be in the setting of severe hypoglycemia and a likely prolonged seizure event. So it was a pretty sad case. He's been in the hospital for some time, underwent trach and peg. And then the on-call team was called to the bedside because he was having more respiratory distress, mild hypoxia while on 40% FiO2 via trach collar. Obviously we still do our physical exams, we still use our stethoscope. So his exam was notable for diminished breath sounds on the left. He did have tachypnea and some use of accessory muscles. And so the team knew that the ultrasound elective residents were eager to get practice on these types of cases. So they actually called us to try and help determine the cause of the change in his patient's respiratory status. So these are his images, and they're correctly labeled. So what do you guys think? So we have the right anterior lung, and then we have the right posterior axillary lung. So what are you guys seeing? I guess we can start first with the right anterior lung, this one here.
Good lung sliding on the right anterior lung.
Yeah, perfect. And would you say it's A-line pattern, B-line pattern?
A-line pattern.
Yeah, I would agree. I mean, I think you see pleura here. You see some A-lines that are reflective of the pleura. So I would agree this looks pretty normal. And then what are we seeing in the right posterior space? I'm seeing a couple people saying B lines in the chat. Excellent. And then what is this sign called? So this is your curtain sign. Yep. So basically you have your liver here, and then when the patient takes a big deep breath, you have the lungs sliding over, obscuring the abdominal structures. And then with the lung that is sliding over, right, you're seeing a lot of B lines that are coming in, right? You have the bright white vertical lines going the entirety of the depth. So this is probably a little abnormal, right? So you're not necessarily sure yet what's going on, but maybe B lines in the right posterior space, right? So then let's take a look at the left. All right, so I'm seeing potentially small pleural effusion, maybe pneumonia. So I guess what you guys all agree what we're seeing here. So I guess, whenever you see something like this, you'd have to try and say, okay, what are structures that we can actually identify here? Honestly, the left anterior, I can't really say for sure what the heck's going on, right? This here is probably the heart that's beating. It looks pretty tachycardic actually. And then there's something here that I would probably call hepatization. I mean, if we are truly left anterior, then this is sort of, this is definitely would be higher than any abdominal structure. So this would already make me worry that there's a lung consolidation. And then when we look sort of in the mid-axillary space, you can kind of make out that this here is the diaphragm. So then everything below that, or to the right of the screen, is sort of the spleen. And then everything above it must be lung, and it looks almost again hepatization. So this is the example of consolidation. So we're seeing a large left-sided consolidation. And then the question is, okay, is this pneumonia? Is this atelectasis? So again, we sort of have to try and pinpoint the Air Bronchograms, or use the Air Bronchograms to our advantage, right? So I would say maybe right here is an Air Bronchogram. And then you want to try and say, for the most part, is it staying still? Is it moving with respirations? Yeah. I think I would have to say it's mainly static Air Bronchogram, so it's not really moving. Yeah. And so static air bronchograms, because if you imagine just the concept, right, it means that there's something within the airway that's blocking air from going in and out of that space. And so the most common reason for that is atelectasis. So this patient, so basically we're seeing large static, large lung consolidation on the left with static air bronchograms, which would be most concerning for atelectasis. Let's see, what do I have next? Oh, oops. So I guess so based on all of this, what do you guys, what's like maybe the working diagnosis for this patient? And I guess what should we do next? And what should be done next could be any further labs, if there's any other confirmatory imaging you want to get or anything else you want. Okay, CT chest. Yeah, chest x-ray, yeah. Yeah, so I think, the whole point is that, we like to have, use ultrasound at the bedside for like a quick assessment, but I think, we should still be getting confirmatory testing. Yeah, so I agree getting additional chest imaging, whether that's chest x-ray or CT chest, I think is appropriate. And essentially, yeah, I agree that the main thing here is left-sided atelectasis. So he did get a chest x-ray. And so this is just showing the chest x-ray. What do you guys think? Does this like surprise you guys? Does this kind of correlate with what we saw on the ultrasound? Yep. I agree with you guys. So pretty much, yeah, I would just call this complete whiteout pacification of the left hemithorax. And yeah, maybe, it's kind of, he's pretty rotated, so it's hard to say for sure if there's mediastinal shift or if it's just a poorly rotated film. But essentially, yeah, the whole left side of the lung is out. So it kind of correlates, right? So it could be something seen with a patient with, extensive left-sided atelectasis. We already know that we didn't really see a massive pleural effusion on the left, right? So I think it's likely, yeah, like Neha was saying, left lung collapse, I think would be the working diagnosis. So knowing this, I guess, how would you guys want to proceed or treat this? Yeah, I mean, ideally, in an ideal world, we could bronch him, right, and clean out whatever's there. It would require a little bit of sedation. We probably couldn't do it at the bedside, but definitely that would be an effective way to clear out his secretions. Otherwise, I think we're kind of stuck just trying to do like, deep inline suctioning. He does have the trach, so we can probably get down at least to the main carina, and then definitely chest PT. Keep him on aspiration precautions. Yeah, Pleura, absolutely. Maybe, yeah, NAC or mucimist or something just to break up the secretion. So yeah, I agree. And that's pretty much what they did. They sort of opted for less invasive measures. And I think, he did pretty well. All right, any questions about that case? Otherwise, we'll go on to the next one. And I tried to, pick things that you guys hadn't seen before, obviously, because the sim session is probably still fresh in your guys' minds. So hopefully these are all new to you guys. So for case 2, we have a 46-year-old man with past medical history of post-substance abuse, metastatic lung cancer. He has known malignant effusion. He actually underwent a left-sided indwelling pleural catheter placement, who initially presented from his oncology office with worsening shortness of breath and weakness. So his initial workup on imaging showed bilateral pleural effusions. He actually had the left side drained. And he also had a large pericardial effusion, which needed a pericardiocentesis. And then since then, he's received a round of inpatient chemotherapy. And then now the primary team was alerted to come to the patient's bedside in the setting of new fevers, tachycardia, and then some mild worsening shortness of breath. And so this is what we saw on ultrasound. This is the left lung. What do you guys think? What are you guys seeing here? And also use maybe some of the clues from the case to think about what could be going on with the patient. And then with that thought in mind, does the ultrasound agree with your initial thoughts, or is there something else going on? What do you guys think? So again, when you don't really know what's going on too much, you can kind of try and identify structures you can recognize, right? So I think, deep to the clip, right? This is the heart beating, right? And so above it, especially if you're looking in the left mid-axillary region, more superficial to the skin, should be lung, which we're definitely not seeing here. And it doesn't look necessarily like a consolidation. And then you have to kind of see, okay, what can we see here? Maybe there's little pockets of anechoic area, right? And then otherwise, it's kind of almost like thick, fibrous, maybe a little bit more consolidative changes within the surrounding area. This here is probably the diaphragm. So this is confirming that this is in the thoracic space. So this is going to be indicative of a very complex pleural effusion. And so in theory, right, if you're worried about, fevers, tachycardia, and then a complex pleural effusion, what's like highest or most concerning on your differential? Thoughts? Nothing? So this is just comparing in comparison with the left side, this is what the right side looked like, just so you guys can get a little bit of difference. What do you guys think here? What are we seeing? Oh, you know what? You guys have been responding. Sorry, I've been having an issue reading the chat. My apologies. Yeah, I was like, oh, I was getting worried that something was going on. Yeah, you guys got what I was implying for the first one. Yeah. So and this is just showing the right side. Yeah. So in comparison, right, you see a nice anechoic effusion. And then what do you think about the size of this effusion? Yeah, I would still probably call it at least moderate to large. Just because you can, in theory, I mean, this is also zoomed in, so I think it maybe makes it look a little bit bigger than it is, but it is at least 2 centimeters deep, right? And then there's at least a couple centimeters between the diaphragm and the lung. But I will say the one thing that may preclude you from trying to drain the space is, as you notice when the patient takes a big deep breath in, right, you're kind of seeing a curtain sign going over the lung, right? So this is a case, you know, if you're trying to put in a needle, right, and the patient's breathing in and out, you might be, it might prevent you from doing another thoracentesis in the space, just because you may hit lung if you do go in with a needle. But and then I would say, you know, this is overgained, so everything's sort of a lot brighter than it should be. So that's why sometimes, like when you do that, you might think that there's something going on like deeper down here, but this is all just a simple pleural effusion, just in comparison with what's going on the left side. So like you guys have guessed with what was going on the left, it seems like the most concerning diagnosis is empyema. So what should be done next? Yep. Yep. I think these are all good answers, right? So definitely the main thing is source control, right? So something like empyema, you know, antibiotics have, you know, limited penetration into the pleural space. So it's just something that definitely needs to be drained. So in addition to antibiotics, you need to have some type of intervention to sort of get rid of all of that complicated pleural fluid that's there. So whether that's chest tube, with like a intrapleuralytic therapy, or even proceeding with something like a VATS if the patient can tolerate a type of procedure and surgery. And then, you know, obviously he does have an indwelling pleural catheter in that space. So, you know, if that space is infected and there's something that's been there for probably too long, that definitely has to come out. And so again, this is just showing the X-ray correlate of what we were looking at. So you can see he has bilateral effusions. It's a little bit more loculated and tracks upward on the left, right? You can even see it going against gravity sort of all the way up here, right? And then this is just sort of, you can make out the indwelling pleural catheter that's in him hanging out in the lower aspect of the pleural space. And then this is the smaller sized, I would say moderate effusion on the right. And then he also had a CT chest. So if we want to look at that, hold on 1 second. So this is just showing again his CT findings. So you can see this is pretty abnormal. If it's going against gravity, like this on the right is nice, normal. The patient's lying down, so the fluid's sort of going down posterior. Whereas on the left, or yeah, on the left lung, it sort of hangs out in the lateral space. So this would be more indicative of loculated effusion. You can kind of make out in this snapshot, this is the indwelling pleural catheter that's coming in. So yeah, this patient had the indwelling pleural catheter removed. He was started on broad antibiotics. He wasn't really a good surgical candidate, so he ended up getting a chest tube with intrapleuralytics to try and get the drain out all the infected fluid. Questions about that case? Otherwise, we'll go through case 3. So again, we have a 72-year-old woman with recently diagnosed breast cancer. So she actually came in with several hours of worsening shortness of breath with exertion. In terms of her vitals, so her temperature was 99.8. She was tachycardic. Blood pressure was okay. She was tachypnic and then mildly hypoxic with 92% on root air. So she's on nasal cannula, started on empiric vanc cefepime, just like every other patient pretty much that comes into the ED with these types of symptoms. And then they did comment that she, at least in the chest X-ray and the ED, was clear. So she was admitted to the medicine team for the workup. And obviously, you know, with all of your guys' excellent knowledge, you decide to ultrasound the patient to maybe try and figure out what might be going on. So already, you guys should already be thinking, okay, what should we be finding in this patient who's, you know, tachycardic, normotensive, tachypnic, mildly hypoxic, and with a somewhat normal appearing chest X-ray. This is the right side first. So on the left of the screen is the right anterior space, and then on the right of the screen is the mid-axillary. What do you guys think? So what are we seeing up here? So yeah, so this on the right definitely is curtain sign, right? So you can make out, I mean, this is the diaphragm that's coming in, and this is the liver, and then you have the lungs sliding in during respiration. And then you kind of want to see, okay, are these A lines, B lines, what's going on? So you see the pleura, there's maybe like one reflection here, there's maybe like one or two B lines, but it would be hard for me to fully say B line pattern in this one view. And then up here, what do we think? So anytime you start off, especially looking anteriorly, you want to know, okay, do we see lung sliding? Is it absent or present? Yeah, there's definitely, good shimmering of at the pleura, right? So this means that the lung sliding is present. So we're not worried necessarily about something like a pneumothorax here. And then what do we see? Do we see more A-line pattern or B-line pattern? Yeah, so A-line, I would say lung sliding with A-line pattern, really in both sides, both views. So pretty normal on the right thus far, I would say. Then we go to the left. It looks similar to the right, different to the right. Yeah, so lumpy bumpy pleura, I would probably say, I would only use the lumpy bumpy pleura if you see like extensive B lines. Otherwise, it might just be like an issue of technique. Because really you're using the lumpy bumpy to delineate whether there's B lines from edema versus some other process. And I would say for here, mostly, I would say it's probably an A-line pattern, right? You have the pleura here, and then you have at least one parallel reflection. And then maybe here you have, again, your curtain sign where this is the spleen that's coming in at the very end. And then when the patient takes a breath, you have the pleura up here with maybe like one A-line here and then one a little bit further down here. So I would say probably for both sides, you have sort of normal A-line pattern. So in a patient who presents like this with a normal A-line pattern on both sides, like what are you guys concerned about? Yeah, absolutely, right? So there's a history of cancer, the patient's tachypnic, they're tachycardic, they're mildly hypoxemic, and they have a normal chest x-ray and really a fairly normal lung ultrasound, right? So definitely I'd be most worried about a pulmonary embolism. So if that's what you're most concerned about, like what might you want to do next?
Get a CT angiogram.
Absolutely, absolutely. Yep. And, of course, you can also look at the heart as well, but that's for a later time. We won't be focusing on the heart in this lecture, or even DVT study as well. But yeah, so definitely starting with the CTA just to really try and confirm the diagnosis of PE. So just and anything else, I have it up there, right? So you want to obviously, once you're worried about PE and PE is confirmed, you always want to get cardiac biomarkers and sort of look at what the heart function is, especially on the right side. So for her, the cardiac biomarkers were negative. The CT angio did show bilateral segmental pulmonary emboli. She also ended up getting a DVT study, which confirmed a right common femoral DVT. So she was started on therapeutic dose anticoagulation. She did fine and actually was sent home after 48 hours. So keep in mind, obviously normal lung ultrasound is a good pertinent negative, right? Because it still can confirm a spectrum of diagnoses that you need to act on. So maybe we'll do at least one more case. So case 4. So in this case, we have an 86-year-old man, his history of hypertension, hyperlipidemia, COPD, diastolic heart failure, and CKD. So he's coming in with worsening shortness of breath, unintentional weight loss. Initial workup in the ED showed a large left pleural effusion. Pulmonary team was consulted. Patient underwent a thora. They actually removed 1.6 liters, and all the fluid studies and everything was sent. Afterwards, he was feeling more comfortable. They admitted him to the medical floor, but then during the initial nursing assessment in the evening, he was noted to be pale, diaphoretic, and short of breath. And so because of this, a rapid response was called. And at the rapid, these were his vitals. So temperature 99.2, heart rate 124, blood pressure was 90/52, and then the O2 sat was 91% on room air. And thankfully the patient was at West, right? And so the ICU intern came with the ultrasound that was fully charged with the IO kits. And so this is what they saw. So we start with the right. What do you guys think? Yeah, I like it. Victor's saying looks good. I agree. Looks pretty good. Normal A-line pattern. Exactly. Yeah, and it's good that you guys, it's good to know what normal looks like, right? So that way we can really be sure when we see something abnormal. All right, so this is what the right looks like. Let's see what the left looks like. What do you guys think? So I guess we'll start with this one on the left anterior view. Normal, abnormal. So I would say, the anterior view, this first view, at least up here, the top looks pretty normal, right? You have the lung sliding, right, with at least one A-line down here. And then we want to try and see what's going on here, right? So again, we want to always identify our structures. All right, I see some people got it. Yeah, some people might recognize this from the Sim Center talk. But so this is the diaphragm up here, right? And then you're not really seeing any clear like pleura sliding, A lines, B lines, right? So is this an effusion? Is this a consolidation? So one tell is that it starts off pretty anechoic, right? As you get close to the surface, it's almost black. And then as you get deeper and deeper, it gets almost like brighter and brighter shades of gray. So this is very diagnostic of a hemothorax. This is called hematocrit sign, where you sort of have layering of blood, where you have the fresh blood up top, and then you have sort of the coagulated blood further down at the bottom. So when you see something like this is definitely hemothorax, and potentially could have been a complication from the pleural drainage that he had earlier in the day. So if you're worried about hemothorax, so what should we do next?
I mean, drain it.
Okay, and how do we want to drain it? Yeah, so I would say, yep, and I see, drain and transfuse, coags, yep, and a lot of people are saying drainage. Yeah, so the problem with, yep, definitely absolutely hold any anticoagulation. Hopefully he's not getting any. So the problem with a thora, like a typical thoracentesis, is that the tube is very small. And so especially if you're dealing with more coagulated blood, it may not be able to adequately drain all of the effusion out. So this is a patient that you might need a large bore chest tube or a surgical chest tube. So this is some situation where you need to call thoracic surgery to try and help assist. And then of course you need to potentially activate massive transfusion protocol, try the CBC, hold any anticoagulation. Sometimes you can even call interventional radiology if the hemothorax was caused by nicking an artery or something. You can do an embolization. And so that's the next case is really just because we are about to run out of time. We don't have to go through it, but essentially it's just a patient with, as you guys can see. What do you guys think?
B lines.
Yeah, so this would be sort of confluent diffuse B lines, right? You can see the hyperechoic verticality going all the way down the depths. So this is on the right, this is on the left. Yeah. So really sort of bilateral B-line pattern. And so what is the most likely diagnosis? I skipped through the history, so you guys have to just come up with a differential. Okay. Heart failure, aspiration pneumonia. What else? Yep, pulmonary edema, fluid overload, CKD. Yep, ARDS. Yeah, absolutely. COVID especially could look like this with ARDS. And then yeah, aspiration pneumonia, pulmonary edema. So what other ultrasound techniques could we use to maybe confirm the diagnosis? So M mode in this case would probably, it would, so M mode is really only used whether you're not sure if you see lung sliding or not. Looking at M mode, it might just look similar to like seashore sign. So echo, obviously, absolutely, you can look at the heart, right, or confirm with what the prior echo shows. And then is there any other lung ultrasound technique that we can maybe use? Talked about it a little bit earlier. It has a kind of a silly name. Especially if you guys are trying to delineate something like a cardiogenic pulmonary edema from, other causes of pulmonary edema, inflammatory process and infectious process. Yeah, excellent. Yeah, so this would be a good time to try and practice looking with that lumpy bump, looking for the lumpy bumpy or fractured pleura sign. And so that you might want to switch to the vascular probe, hone in on the pleural line itself and make sure, okay, is it smooth? Is it fragmented? Is it thickened? What does it look like? And in this case, let's just say it was smooth throughout. So a smooth pleura with extensive B lines. What would you guys think is the most likely diagnosis? Yeah, and Patricia's asking, could we measure the IBC? Yeah, absolutely. Yeah, we can say that the IBC was plump, just to go along with the diagnosis. Yeah, so this would be, with all that put together, it would be most concerning for a cardiogenic pulmonary edema type process. So then you may want to, depending on the scenario, put the patient on positive pressure like CPAP or BiPAP, diurese the patient, right? Make sure that their heart failure meds are optimized. So I think with that, that's all I have. Of course, we always like to pitch our wonderful POCUS corner. That's part of the chief website. I can't take credit for it. It was already built up long before I started. So, but it's a very excellent resource. And of course, if you want to practice your lung and cardiac ultrasound, we have the Ultrasound Simulator. It's available to use in the SimRK 24 hours a day. And I know sim sessions were on hold for a couple of weeks just with everything going on, but hopefully when you guys are returning back to the sim lab, you'll be learning a little bit more about ultrasound. Any questions?
Where's the ultrasound simulator located, Dr. Rothman?
Yeah, so the ultrasound simulator is basically you have to make your way through to 8G, and of course right now there's like two like solid doors there because it's like an active psych unit. So so you have to essentially go past the sim lab and go towards 8G, past the doors, and then it's the first door on the left. You'll notice that there's something where you need to use your badge to access, and it's actually the office that Priscilla usually is stationed in. And so you can go in through there, and it's open 24 hours a day. It's essentially past like all the critical care offices, and it's the next door on the left.
So much. And I guess if there are any questions, obviously you can just type